So are people in now?
They're starting to come in now. So yes, so slowly and surely we have folks coming in. Hello, hello, everyone who is joining us. We're going to get started in just a moment or two. We're going to give it a little time, as I know this is lunchtime for some folks and early in the morning for others. You'll notice that your lines are all muted. Feel free to use the chat box if you want to say hello. We'll be interacting with folks along the way in this session. Thank you again for joining us. We'll get started very shortly. Oh, and a good reminder, I just looked at the chat box. Because we're in a webinar, if you want to connect with everyone in the room, the little chat box is going to default to host and panelists, but you can drop down and you should be able to chat to everyone. And certainly the panelists will be able to see your questions anyway. And thank you, Juliet, for putting that in. Excellent. All right, so I know we'll have more folks join us, but I want to be mindful of the time, so we will get started. So again, hello and welcome to this webinar entitled When the Loneliness Remains, Supporting the Social Needs of Older Adults Beyond the Pandemic. Some of you may have joined us last year where we had a similar topic where we focused on, we were just a few months into the pandemic, thinking about social isolation and loneliness as a broader concern for older adults. And while we certainly acknowledge all of the challenges that have happened over the past year, we're very excited to bring back Dr. Peter Miramaldi, a wonderful member of our team, to discuss this topic again in light of not only the pandemic, but in thinking about supporting the needs of older adults going forward. Go to the next slide. Sorry about that. So if you are not familiar with our center, just very briefly, we provide training and technical assistance to community health centers and similar organizations across the country. We welcome you to stay connected with us. There are social media links on this slide and our website. Feel free to check out other upcoming training opportunities. We would love to see you there. We'd also love to hear from you around any topics you're looking to learn about through webinars or learning collaboratives or publications. And speaking of those types of training and technical assistance resources, the Health Center Resource Clearinghouse, always a place we like to plug if you're not already familiar with it. In particular, this slide is focused on the priority topics page for COVID-19, a lot of great resources for vaccination and vaccine confidence. So we encourage you to check out that priority topics page if you have not already. And the very standard Zoom reminders that we are all familiar with by now. As I mentioned at the start, your lines are muted just to prevent any background noise, but we would love to hear from you. If you have questions or feedback, feel free to use the Q&A feature or the chat box. We will provide both the recording to this webinar as well as the slides. You'll receive an email with that information after this session wraps today. And of course, we would love to hear your feedback. When you close out of this Zoom window, you will be prompted to fill out a very short SurveyMonkey. We would love for you to give us your feedback and evaluation at the end of this session. And with that, I will turn it over to Dr. Miramaldi. As I mentioned, he is a team member with our center, as well as a professor and former director of the social work program at Simmons University. He's also an adjunct professor at the Harvard School of Public Health and the Harvard School of Dental Medicine. So we welcome Dr. Peter Miramaldi. Thank you.
Thank you, Ariel. It's always a pleasure to work with the NCEC team. And I'm especially thankful for the opportunity to present about social isolation and loneliness again. It's been just about a year since we did this, and we've all experienced it firsthand. I think you've all read these learning objectives, so I'm not going to go through them, but I hope that we will cover all of this. And if you have specific questions about anything, please don't hesitate to put it into the chat or the Q&A. And I'm going to leave for about 5 minutes at the end for questions. Please, next slide, Ariel. So very quickly, this is sort of like almost a duh question, but if you would just like respond to this, we'll get a sense of, do you think older people are more likely to experience social isolation and loneliness than younger populations? What makes this interesting is the pandemic heightened awareness of social isolation and loneliness for this population. And before that, it was sort of a quiet epidemic. So it's an interesting thought. Can we go to the next slide, please? Thank you, Ariel. I think you're all aware of a population shift, and projections vary, but in general, this is what we see is by, over the next decades, we're going to see a huge increase, almost a doubling of the older populations, age 65 and older in the United States. In 2060, 90, you can see this, but if we go, oh, here we go. Here's the poll. Is it being published yet? No. Let's go to the next slide, please, Ariel. What's deceptive about this is while we know there's this population shift occurring, this is a distribution of the United States population. This is the most recent data we have available. I like this presentation. If you look in the bottom here, you can see the boomers age 55 to 73. And you see in the oldest, there's not a lot of them. But if you think about the places where you work, the organizations, the institutions, if you're a provider, a direct provider, the people on the right-hand side here in the silent generation, even the boomers, are more likely to be presenting with problems, health issues, or social needs that will determine their health than the younger generations. Next slide, Ariel. So while there's fewer of them, they may have greater demands, and there's data to support that. This is just a slide I put in. This is from a profile, most recent, the American ACL, most recent, where older people reside. And you see the lighter areas where there's the higher concentrations of older people. That doesn't mean that if you're in Utah or Texas, there might not be an enclave of older people. So never let these kinds of stats be deceptive. And if in your own clinic or wherever you're working, you may see high concentrations of older people. And when we get to the end of this presentation, some ideas of how you can keep them socially connected with others. Next slide, please, Ariel. So obviously, living alone is a risk factor for social isolation, but not always. We shouldn't assume that. And you can see here that, and again, this is from the US Census, and it's the most recent data that I could put together, is how people are living. And you'll see more women than men live alone. And if you know any older men, especially over 80, 85, they're hot commodities. When we moved into our neighborhood, I met the lovely woman next door walking her dog who was 91. And I told her my dad was in his late 80s. And she looked me dead in the eye and said, I'd really like to meet him. It's a very interesting dynamic that occurs with older folks. So just be aware of the fact that they have dynamic lives and this very active social lives when they're not isolated. Next slide, please, Ariel. So if you look here, these are physical functioning. I hope you can read this, but the top three, starting the highest, 40% people age 65 and older with physical functioning issues have difficulty with mobility, followed by hearing. Hearing loss is devastating. If you know anyone with hearing loss, or if you have patients coming into your facility with hearing loss, that is an absolute risk factor, as is mobility and difficulty with cognition as well. And you can look at the rest of them, but these are typical risk factors, things that we look for when we're trying to get a sense of is somebody at risk. Next slide, please, Ariel. At risk for social isolation or loneliness. I put this slide in here because I found it interesting. This is the percentage of people reporting symptoms of anxiety or depression. And it's by age group. And what you can see is the older populations have the lowest, my light just went out, so thank you, have the lowest reports of anxiety or depression. But this can be very deceptive, and this can be deceptive because of detection. And it's also a way when we think about behavioral health services, we mustn't overlook, if you're so tightly focused on anxiety and depression, it's important not to overlook the needs of older populations either. Next slide, please, Ariel. And please, any questions, put them in the box, in the chat box or the Q&A. Just to be clear what we're talking about here. Here's a definition of social isolation from an early round of the Institute on Medicine, which is now the National Academies of Science, Engineering, and Medicine. And you can read this yourself, but then we talk about social isolation as being voluntary or involuntary absence of contact with others. The voluntary part is very important because sometimes people don't want to have contact with others. And then this notion of being objective and subjective. Social isolation and loneliness, this sense of feeling of being isolated and alone. It's a very subjective, and it's important to remember that. Next slide, Ariel. So, I mean, there's the literature on this. If you're interested, all these slides will be available. If you're going to be doing trainings, I notice some of you will be training staff. If you need to have evidence, I put a few slides in here. But the idea is that it's possible to feel lonely while you're in a relationship. Just because someone lives with someone else or lives with their family, a grandparent perhaps, it doesn't mean that they're not feeling lonely. But it's also possible to feel satisfied when you're not having social relationships. So that's why it's so important to evaluate each individual separately and not make assumptions about any of these things. Next slide, please, Ariel. And here's my favorite. It's strange to be known so universally and yet to be so lonely. I think people still know who this person is. Sometimes my 21-year-old graduate students don't know who people I grew up with are. So it's always a little scary to me to put up a picture like this, but I hope you get the point. Next slide, please, Ariel. So this is really interesting. The 19th Surgeon General of the United States in 2017, before the COVID lockdown, before the pandemic, declared loneliness as an epidemic, and cited this. There was a lot of press releases on this. There was a lot of reaction to this, and you've probably heard it, that loneliness and weak social connections are associated with reduction in lifespan, similar to smoking 15 cigarettes a day. That's the impact on somebody's health. I don't know, 15 cigarettes a day, I think we're universally at this point in our country's history, we have a good sense that that's not a healthy thing to do. But before the Surgeon General did that, did we understand that? Now it happens that Dr. Murthy, who's here in Boston, well, not right now, but Dr. Murthy became the 21st Surgeon General of the United States after the pandemic, and has written, in between, wrote a very interesting book. You can find it easily, but the whole idea is that when he declared this in 2017, it was picked up by sources like the Harvard Business Review. And the idea that, and that's why the citation is there, the idea is that this was out into the general public prior to the pandemic. Next slide, please, Ariel. This is where all that data comes from. And you're going to see it referenced if you have any infographics, if you are reading about this, if you've read articles about it, and people say it's comparable to smoking 15 cigarettes a day. Julianne Holt-Lunstad did seminal work in this area. And she did very technical scientific reviews and came up with these kinds of data. Next slide, please, Ariel. And again, prior to the pandemic, HRSA was on top of this, and they had resources. So this is still up on the page, on the HRSA page, but you can go and find tremendous opportunities in the HRSA and the other federal resources on explanations. Go back one slide, please, Ariel. But if you prefer, I would send you to the primary sources. And Lundsted's work is just phenomenal. And there's some very effective demonstrations associating isolation and loneliness and lack of connectedness with very specific health conditions. Can we go ahead 2 slides, please, Ariel? Thank you. So I just answered this question, but what do you think of the effects of social isolation and loneliness? I mean, before that, what you, in your own language, what would you have said? And I want you to think about it in the context of yourself and your colleagues as well, and maybe into your personal life. How do people think about this? I think the pandemic had a pretty significant impact on perceptions of isolation and loneliness. I know in the the local news and some of the national news. I try to watch news on TV, but sometimes it just seems so slow the way they present it, and I have zero tolerance for commercials. But I can't even count how many times I saw family members standing outside of a window with an elder in a nursing home. And it really drove home the point. It was a very compelling image. And so we've heightened awareness about this. Next slide, please, Ariel.
I just want to acknowledge that we did have one person come in the chat, and I would love to hear, even just take 30 seconds if there's anyone else who wants to share. See someone sharing depression, potentially weight gain, eating disorders. So certainly could impact how folks are feeling about eating. If there's anything else, I loved the way Dr. Miramaldi framed it of, yes, we mentioned a couple of things on other slides, but what you've seen or what you've experienced in the past 19 months, if it is something that the pandemic has influenced for you. I see levels of dementia, lack of mental stimulation, physical limitations.
Excellent.
Disinterest in talking and mental and physical decline, suicidal ideation.
Excellent.
Yeah, I appreciate everyone sharing, and certainly you can continue to share. I'll continue to mute myself and move on along, but just wanted to see what folks were seeing and appreciate those shares.
And if you look on this slide, you hit them all. Isn't that interesting? And this is, taken from a Suicide Prevention Resource Center. And it's impressive that you cover just about all of these. And you can see that some of these are actually physiological conditions as well. And that's where the comparison to smoking 15 cigarettes a day comes in. It's just there's real strong, solid, convincing evidence that there is and there are associations between isolation and these conditions. So the question is why, and we'll get to this in a little bit. If somebody comes into primary care or they come into a health center, we'll ask about smoking. We'll ask about safety issues. We'll ask about fall prevention. But do we ask about loneliness? And I'm going to show you some ways to ask about loneliness and some ways to measure loneliness, and hopefully some resources that might be able to address it. I always have issues with asking about something and not being able to address it. But it's probably better to collect those data, and I'm not the only one saying that. You'll see that in a couple of slides. Next slide, please, Ariel. This is the slide. The National Academy of Science, Engineering, and Medicine did a consensus study in 2020. Now, this means that this was launched and began before the COVID epidemic, but this is an excellent resource. It's your tax dollars at work that make this available. Actually, this is a nonprofit organization. It's the donations to this nonprofit organization that make this available to you at no cost. And if you're interested, I would very strongly recommend that you download this, and there are actually some summary pages. If you haven't seen these kinds of reports before, they're very good. Next slide, please, Ariel. And here's some of the summaries from the report. And again, it's a very comprehensive review of the literature that was available at the time, arguing that almost a quarter of people, community dwelling Americans over 65, were considered to be socially isolated. That's astonishing, with 4% severely isolated. And again, this was in part driven by the Surgeon General's assertion in 2017 that this was an epidemic, this notion of loneliness. You can read the rest of these. The interesting thing here is that it can be both episodic or chronic. Now, the chronic isolation is very important to address, but episodic loss of a loved one, I'm going to show you some risk factors here, but it's just important to understand that. Somebody may come in, if you're in a primary care, if you're in a community health center, if you're in an agency in a community, somebody might be great and come back a month later and be completely isolated. And that's why it's important to keep vigilant and keep aware of these things. Next slide, please, Ariel. Just some more, this is taken from this consensus study. Again, these slides will be available to you, but just an idea that there's very strong research and evidence supporting these assertions. And you can see that there's variation in the percentages, but these are from different parts of the country through different organizations. Next slide, please, Ariel. Yes, I love that, where you get a sense of baseline in the chat, and you can see, and their physical appearance changes. It's so important to keep that in mind. What this consensus study came up with, and they always have to come up with these I've worked on many of these, is this notion of social connection. And it's, if you think about it, we're looking at it from the other side. You're either isolated or you have connections. And the idea of what are the connections? It's probably an easier way to make observations. And they came down with 3 areas, this consensus study: structural, functional, and quality of relationships. And you can read these for yourself, but the idea is the functional is the thing that's often left out. Just because I have a strong family, just because I belong to a faith community, just because I go to the senior center, doesn't mean that I have relationships. I may just be there and I may still feel isolated. So it's important to think about it along this continuum. And if anybody has observations, please don't forget to put them in the chat or the Q&A. Next slide, please, Ariel. Again, all of this is available to you. I put more articles in here from the scientific literature for those of you who are interested or doing trainings. You may notice that, and if you come back and look at this, I wasn't confident with anything that's coming out yet, and from during the pandemic, and I'll explain why in a moment. But this is an interesting study on the epidemiology of isolation, social isolation. And it's, again, this is the sources of some of the things that you're seeing. But what's of note here, if you look at these risk factors: older, and you can see the intervals, unmarried, lower education and lower income, male, interestingly enough, and we saw in a previous slide where males were less likely to be living alone, and people who reside in non-metropolitan areas. Now, that's not to say if you live in New York City and a fifth floor walk-up, you're not completely isolated. But remember, these are just trends. These are just general trends that are being observed from surveillance. What I find most interesting here is that the 90+ people were almost 3 times the rate of experienced severe social isolation compared to being connected with anyone. And I once had a 90-year-old roommate, and when he was 96, he committed suicide. And I remember at his last birthday, he said, "This is the last one for me." And I said, "Why?" And we were crying. I was tears rolling down my face. And he said, "Everybody's gone." And I was moving back to New York, and he was in Philadelphia, and he stopped eating. He just stopped eating, and he committed suicide. And I'll never forget this gentleman. And he just couldn't, and he couldn't leave. He couldn't move to New York with me. He spent 96 years in Philadelphia. But this idea of being completely isolated, he outlived everybody in his life. He outlived his great-grandchildren who died violently on the streets of Philadelphia. So, I mean, it's just something to think about when you have older people come in. You're going to screen for so many things, but do we screen for loneliness? Do we screen for isolation? It's critical. Next slide, please, Erica. More risk factors. What's interesting here is that this study found that Black and Hispanic, and if you can use that term, we say Latino or Latinx now, older adults are less likely than white people to experience severe social isolation. Why? I mean, there's a whole literature. I don't want to go down that rabbit hole now, but just to get an idea, that doesn't mean if someone's a member of one of these groups, they're not socially isolated. And you can see more risk factors. And those of you doing trainings, you can pull these articles easily. They're in the public domain, and you'll get a real sense of very rich data. Next slide, please, Ariel. This is from AARP. I'm not endorsing or promoting, and I have no conflict of interest with AARP. I just have tremendous respect for how they're able to aggregate enormous amounts of information. And this is a wonderful chart. And if you go to the web page, you'll see this gets pulled down. But if you look here, you can see risk factors in there's 3 columns on each of the 2 columns. There's 3 columns. The risk factors, are transportation challenges. That makes a lot of sense, right? And I went on a ride one time with someone. If I got, I was at their house, and then I got on the van and got transported to a large urban clinic and went with them into the clinic to be seen by a provider team. Waited, got back on the van, and went back to the house. I was wiped out, and I'm a young, healthy person. I was completely wiped out. So transportation is so critical to think about. And I know many of us do, but how many of us have taken the ride? How many of us have a sense of what that's like and what the deterrents are? So what's really interesting for the AARP page is to think about the causes and some common responses. And the notion of a volunteer-based ride program is wonderful, but not always possible. It's a lot different than having somebody making whatever, 15 bucks an hour, maybe $12 an hour, roll you onto a van and not talk to you, as opposed to having some social connection with that. And that's not to say that people who are employed this way aren't very caring. I've seen some amazing, I can tell you amazing stories how people went above and beyond the line of duty. And by the way, those people picking people up in their house, they're a tremendous source of data for going in when they're picking somebody up, fall prevention, abuse of elders, things like that. We train them to be able to detect things, to have somebody up front and close and personal. Let's just go through a few for health and well-being. I think that's pretty obvious. But this notion of what are the responses that we can do? Number one here, untreated hearing loss, not knowing what's going on. You couldn't possibly be more isolated. And it's something that's very often overlooked. And it's important to remember, those of you who work with older people, you know this, a lot of time they fake it. Oh yeah, and they'll just try to go along, try to hide some of the deficits that they're experiencing and the losses that they're experiencing. Sometimes they'll tell you, but it's important to be tuned into this. Life transitions, there's nothing more devastating than losing a friend. I see this all the time, and it's so compelling. A spouse dies, they lose their best friend, they lose their lover, and they lose their job when their spouse dies, taking care of their spouse. Everything's gone. These kinds of life transitions are absolutely critical to be aware of. You all know this, but in terms of this epidemic of social isolation, to think about what a risk factor this is for health, and not just mental health, but overall health. When I say health, I think mental and physical health, but overall health. And that's where you can see, again, this AARP page, some of the responses. I'm going to show you some of these opportunities as well. And then social barriers. Ageism is an entire webinar. We could talk about that and how important that is, and how intergenerational programs are like a tonic for older people, but very difficult to launch. This notion of lifelong learning, there's so many ways that manifests, from actually having elders in university classrooms with undergraduate students, 18, 20 years old, to just something in a senior center where there's a training where people learn something, a new technique or a new skill. And then this inequality, the lack of access and inequality, poverty, rural living. I could show you cases, I could show you published articles. I use a lot of these kinds of articles in my teaching with graduate students. But, and the other thing that's really not listed here, if a person doesn't have resources, if an older person goes into the healthcare system without an advocate, they're at extreme risk. It's very difficult. And then we mustn't forget marginalized group, minority groups in any given setting, LGBTQ, etc. These are the people who are often overlooked and at great risk. I was in Texas, and I saw a home sharing model that was so impressive, but how do you bring something like that to scale? It's so difficult to bring these kinds of programs to scale. And this is where, we put on our thinking cap and try to, in our own settings, come up with ideas. I just think this is a terrific slide. I would direct you to the AARP webpage. We're going to go back to that webpage in a little bit, but it's just a rich resource to get a sense of risk factors, and just a very cursory overview that there is hope and there is a way to try to address some of these things. Next slide, please, Ariel. Back to the National Academy's report, and I just highlighted here what I wanted to say is that it's important to assess. And I said that earlier. I mean, we're going to assess for so many things in healthcare settings and in community settings. Do we assess for social isolation and loneliness? If you have the capacity to include this as a data point in an electronic health record, that would be great. That was a recommendation that they made. But those of you who work across institutions, or if you have somebody you're seeing in your institution and in your health center, and then they go to an emergency room, do you have the same electronic health record? Do they speak to each other? If you're in Denver, you might be in better shape. If you're in Colorado, but in many places, there's these transitions that are so dangerous. But at the very least, in your own center, if you have data and you're collecting data on this and have a solid record, it's very helpful. And we're going to talk more about connecting patients, but these are the recommendations that came out of this consensus study. Next slide, please, Ariel. Part of the reason I didn't include I pulled some recent articles that were conducted, and they are typically from existing data sets or pulse surveys, things where there were assessments for social isolation and loneliness during the pandemic. But they were using a lot of these scales. And if you see the dates on some of these scales, they're concerning. The question to you is, do you use any of these in yours, in your settings? Most of these are used, except for the last one, are used in research. And this is what you'll see a lot in the literature. Those of you who are academicians, you'll see these referenced as a measure very often. Very often, in secondary analysis of large data sets that are often representative and thus very powerful when we talk about population science. Next slide, please, Ariel. Ariel's giving me the don't get geeky sign. So this comes also from that National Academy study, and these are the ethical considerations. Just what I said, some of these relevance aren't, some of these assessments may not be relevant. And this potential exposure of elders to exploitation. I've gotten some pretty horrific robo calls, and every time I get one of these calls, this is the IRS, call this number immediately. I can't tell you how many times I've tracked these numbers down, called my local police, called my local FBI, and they always say the same thing. We know this is out there, but we just can't do anything about it because I don't know how they hide the phone numbers. Many of you have probably gotten some of these calls. But these are some of the considerations. And the bottom one I think is really important is that low risk populations may be left out with these kinds of assessments. So that's something to consider. Now I'm going to tell you why you should use assessments. Next slide, please, Ariel. These are the questions you should ask yourself. Are you comfortable to ask direct questions about social isolation and loneliness? Again, go to this website. This campaign to end loneliness comes out of the UK. It's wonderful. And I think if you go back to your organization, I was very impressed that so many of you in the registration said that, 4s and 5s ready or very, very ready to start implementing change. These are important questions to ask. How much time do you have to ask people about loneliness? I mean, think about how the competing demands for time during any kind of a clinical or even a social contact. Who's going to be asking the questions, and how are you going to analyze the results? And then what are you going to do when you get the responses? What are you asking about? And I think that's very important. But this is an important thing to ask yourself. And it's important to be able to make these kinds of commitments for yourself, for your colleagues, for your organization. Next slide, please, Ariel. Again, how many questions? Are you going to word the questions positively or negatively? These, if you're going to do your own assessments. I personally like one question assessments. I don't think they always work, but it's a way to think about it. And how does it work across cultures is so critically important. Is it culturally and linguistically, what you're asking, is it culturally and linguistically relevant for the people you're asking the question to? And if you're embedded in a population and you know your population, you probably know that better than the research wonks who are developing these. But you have to get a real sense of the psychometric properties, we call it, if these psychometric properties apply to the population you're working with. So sometimes just asking is better than nothing. And I like this, the L word. Sometimes people are afraid to ask it. I think the pandemic has done wonders in that regard, is that we're not afraid to talk about loneliness anymore. And it's something that younger providers and younger people are aware of and willing to talk about more than they were in 2017, for example. Next slide, please, Ariel. So this is just a quick view of 4 from the Campaign to End Loneliness. Possible, these are candidate assessments. The Campaign to End Loneliness measurement scale, they said that's scale 1, that's self-serving, but it's 3 questions. There's positive wording, and it's really for providers of services. It's not designed for researchers, which is important. Does it mention loneliness? No. And the scale, if you want, it's very easy to use, as opposed to some of these other scales. Now, if you go down to 3 here, you'll see the UCL loneliness scale. I see this a lot in the literature, and some of you may be actually using this. Again, 3 questions, has negative wording, also for service providers, and it doesn't mention loneliness either. And it's quick, it's been psychometrically tested, and it's relatively easy to use. So you'll see that often. And so I wonder if anybody uses that, if you would just say so. I'd like to know what your experiences were with that scale. Then if you go to 2 and 4, these are designed for researchers. The John Graver loneliness scale, 6 questions, mixes positive and negative. And then the single item scales, negative wording, and it's for researchers. And does it mention loneliness? Yes. Are you lonely? Do you ever feel lonely? Questions like that. Any comments or questions, please put them in the chat, and we'll go to the next slide, please, Ariel. So just as an exemplar, here is the Campaign to End Loneliness measurement tool. Quick and easy, and I don't know how you feel about it, but I guess I'm too indoctrinated. But when I see a Likert scale, I remember the first time I did one, I thought it was awkward. So sometimes if you're going to do this in a clinical setting or in a community center or wherever you're working, it's helpful to walk through it. Do you strongly disagree, neutral, agree, strongly agree, or don't know? I'm content with my friendships and relationships. And that's how people respond. I have enough people I feel comfortable asking for help at any time. My relationships are as satisfying as I would want them to be. Now, I have a lot of critiques of this, but it's a quick and easy scale to present. I wonder what your reactions would be if you could try to do this for yourself, or you could try to do this for someone else. And it's easy to score. Next slide, please. And you see the reverse coded. Thanks, Ariel. They're reverse coded. So strongly agree is 4, and you just add up the 3 scores. And the higher you get on the scale, the more lonely you are. And it's just a way to collect these data every time somebody's being seen, say in your community health center. If you use this scale, if you do use a different scale, I hope you can see the advantage of this kind of surveillance, where you just keep, for every visit, you take blood pressure, you weigh people, you measure people's weight. Why not try to measure the degree to which they're lonely? Because social isolation and loneliness has dire health impacts. Why don't we collect these data as well, as critical as any other data we would collect? Next slide, please, Ariel. So let's go to the fun part, resources. How are we going to do this? And this is those of you 4s and 5s. I strongly recommend using infographics. If you don't have these in your workplace, wherever your huddle, the water cooler, wherever people congregate, it's so important to remind people of these things. And I'm sure you're all familiar with these. This is I just pulled this off the internet. And one of the easiest things to do is just do a Google search and find an infographic. Just say social isolation and loneliness for older people. Type that in and see what comes up. And you can put in languages too, or cultures, and see what comes up. I put this one because I liked it because it was pretty comprehensive. It shows some risk factors and it shows some responses. Now, these may not be appropriate for the population that you're working with, so look for something else. But the internet's a wonderful thing when it works well. It can be a wonderful thing. It will provide you with so many resources like this that you may be able to match to your organization. A lot of the federal resources now are excellent because they present material in multiple languages and with some cultural awareness, increasing cultural awareness as well. And remember, cultural and linguistic relevance are absolutely crucial with any given population. I think these are most effective for staff. And when I say staff, I'm not just, if you're in a health center, not just the clinical staff, but for the people on the front desk, for the people doing transportation, for everyone. It's so critical for people to be aware of this. My favorite story is at NASA, one of the astronauts came back late, Saturn V rocket moon launch, and there was a custodian sweeping one of the platforms, and he said, what are you doing? And the custodian looked up at him and he said, I'm putting a man on the moon. Everybody's part of this. Everybody's part of this effort. Yes, caregivers, absolutely. But how do you engage caregivers? And again, I think this is where the pandemic was very helpful, because the caregivers will have a greater capacity to empathize with the notion of loneliness. Next slide, please. Now, here's a terrific resource that you might use with caregivers. Again, no endorsement. I'm just happen to respect what they're doing. You can search up this AARp webpage and tools to overcome social isolation. Next slide, please, Ariel. You see this little infographic on the right? See how powerful they are? I love them. And this, you can go online, take this assessment. I did this assessment about 7 times. And no matter how I did it, it said I was at risk for social isolation. And then it gave me some resources. This is something you might be able to do with a caregiver, because when you click on that, and we're not going to do it live here, but if you click on that take an assessment, it says, I'm conducting this for myself, or I'm conducting this for someone else. You could sit with a caregiver and say, let's do this for your care recipient, and answer the questions. And then when you compilate the score, it brings up potential resources. Are they comprehensive? Yeah, they're okay. It's more than nothing. It's a start. But it's a way to convince caregivers that it's something that they should be aware of. And it's something that you could even do with patients, to sit down with a patient and have them do that. What I like about these is that they're free of charge, they're easy to administer, and people can share them with each other. The danger is that people get sophomoric about this stuff, but it's really, they're very valuable. Next slide, please, Ariel. So what's really interesting right now is the public-private initiative between the government and private entities. And you can see on this list here, each one of these, if you go to the webpage, is a live link. All the links in our slides work as of today. But if you go into these web pages, this Commit to Connect campaign, and it gives you a sense of opportunities and where you might be able to get ideas. If something's not directly appropriate for your workplace or for your population, it may just give you some ideas and lead you down other opportunities. We could spend a whole hour just going through this. For me, this is very exciting to see this compilation. We'd have to search all over the place 15 years ago, 10 years ago, 5 years ago. We'd have to search all over the place, but this is the wonders of technology when we're bringing these together, and these public-private endeavors are very powerful. Next slide, please, Ariel. This National Institute on Aging. So the NIH webpage also has, and if you look here, infographics, click on that. See, there's something you can hang up in your workplace, something that might be helpful. And just a tremendous opportunity with these resources. And I think you have to, you can take what you want. It's almost like shopping, and you're going to tailor whatever you extract from these resources is going to be tailored to the population in the teams that you work with. And it's important that the teams buy into these things. And I think a lot of these resources come with credibility that maybe make it more possible to work with the teams. Next slide, please, Ariel. I really encourage you to pull all of these if you can. If you click into the NIH webpage, you can see this tips for staying connected. You know, these aren't the greatest, I don't think. Some of them are very viable, and some would might be perfect for a population or an individual that you're working with, and others are just too broad. But they're there, and there are opportunities. Next slide, please, Ariel. Again, more resources. What's interesting here is this create connections using technology. It's the second one down. Technology is tricky. A lot of people think technology is great. One of the early technology and aging researchers is up here in Boston, Diane Mahoney, clinical nurse practitioner, PhD nurse researcher. I'll never forget, 16 years ago, I met with her. And I said, what about technology? I'm so excited to meet with her. She was very senior, and I was relatively new and just new to Boston. And she said, it's great, but it doesn't beat the mailman. I said, what does that mean? She goes, at the time, with the technology, they would have radar in the room to know if somebody wasn't moving around. But she thought the human contact was more important. Isn't that interesting? So that's a cautionary tale I always think of about technology. Next slide, please, Ariel. Having said that, here's a resource, guidelines for delivering tele wellness programs to older adults with disabilities. Wow, if that works, wow. And it's something to consider. If you're in a rural area and maybe you have bad internet, we're working on that in Congress, we're trying to get that going, but it's just something to think about. And I'm just putting this out here as an example of a previously extremely difficult population to reach, maybe being reached and needs being addressed through technology. Next, take a look at it if it's relevant to you. These are the types of things that we see in technology using to address social isolation. Reminder Rosie's a riot. Now there's the computers and robots and things, but again, I just caution everyone, take all of this with a grain of sand. I'm working on a project with a group in San Francisco. We're using we assume that everybody has a smartphone, but then when we did some pilot testing, it was extremely difficult to operate this computer. Oh, I got the computer, but I'm not sure how to use it. So, I mean, it's really important to think about these things. Next slide, please, Ariel. This is one of my favorite federal tools. These are your tax dollars at work. If you go to this Health and Human Services webpage, HHS.gov, and you click this aging area, you click on this elder locator. This is the link. Go to the next slide, please, Ariel. Thank you. Put in your zip code, and it'll bring up a treasure trove of resources. I hope. I test this out all the time. If we were live, I would do a couple of yours now. But it'll send you at the very least to the area agency on aging, the AAA in your local area, and we'll connect you to all kinds of resources. So I strongly suggest, if you don't use this already, to start using it and see what you can come up with. Next slide, please, Ariel. Faith-affiliated senior support care may vary, but these are the kinds of that I was able to find faith-based services that reduce social isolation and loneliness in seniors. There's a whole social structure that goes with these as well. But for some people, these are terrific resources, and it's just something to be aware of if you're not aware of it already. And if you're not affiliated with a faith community yourself, maybe somebody you're working with, or you're in a population, that this would be an extremely valuable resource. But again, like all referrals, you have to be very careful. Next slide, please, Ariel. I don't know if you're familiar with this notion of the virtual retirement communities, aging in place. It's very interesting. You can take a look at this link, but it allows people to stay in their network of neighbors and friends and develop some sort of a community. There's a lot of this kind of approach emerging. If you're not aware of it and you're working with an elder population, you should try to make yourself more aware of it. And I could talk more about this, but I'm going to stop in 5 minutes. So I just want to if I could please encourage you, if you're not aware of virtual retirement communities, and I'm going to show you some more. Next slide, please, Ariel, just to try to get aware of it, because you may come up with a better idea that fits your population. These tend to be expensive. And this is not an endorsement. That's just an example of one. I visited many of these around the country, and I visited some with memory care that are very, very impressive, but also very expensive, and they exclude vast swaths of the population. But the idea of a continuing care community is that you start in this community when you get a little bit older, the boomers, and at each level of care, you're probably familiar with these. You may start with an independent living, and then you might be in some sort of supported living, and then you might go into assisted living. And if your condition continues to deteriorate, you would shift into skilled nursing. But it's this continuum of care, so that you don't have this disruption of moving far away, or this transition or this transfer away from your community. Some of these are wonderful. They have raised vegetable gardens and things for people to work on. And it's just wonderful. Next slide, please, Ariel. Not as wonderful as this, and these are few and far between, which are multi-generational retirement communities. I had the good fortune of discovering this one outside of New York City. And it's based on anthroposophy. It's from the Rudolf Steiner schools. That's a Steiner teacher with Steiner school preschoolers, and they celebrate all the holidays. And what happens is it's a continuing care community, but in the continuing care community, everybody who works in the community who also lives in the community, and they prepare meals together. And the more one's physical condition deteriorates, the further in they come to what would be in effect skilled nursing. But the skilled nursing facility has the sounds of children playing, of parents arguing, of food being cooked and pots being cleaned and vacuums. And it's just life. It's what people did instead of think about somebody who spent their whole life providing for others, and you stick them in a nursing home and they sit there in deadly silence all day and don't move. It's a warehouse for humans. These kind of multi-generational retirement communities are just rich with opportunities for healthy aging. Next slide, please, Ariel. And again, this is for more resource people, but hopefully we're going to see this more in public housing, is this home within a home idea, where there's space for an elder to live with a young family. Next slide, please, Ariel. These naturally occurring retirement communities, the Beacon Hill Village is one of the oldest, but I wanted to give you this web page. It's very interesting, this village movement. Next page, next slide, please, Ariel. This village movement. Recently, I've been trying to observe this. Now, this goes everything from, I don't know if you have Dunkin' Donuts, we call it Dunkin' now, Dunkin' Donuts. I'm not endorsing any company or anything. Or McDonald's, I'm not endorsing McDonald's or anything. But I'd love to see a group of older people sitting around the table, drinking coffee, just jawboning, talking. This kind of naturally occurring support group that every morning they go and they meet. And if somebody doesn't show up, they go and check up on them. My mother-in-law lives in a community where this occurs, and the ladies every Friday have lunch together, and if somebody's not there, there's a big red flag, and they take turns at each other's apartment, these sorts of things. But this village model, they'll go on walks together, they'll have lunch together. I found a group down on the Boston Harbor that just did part of the, what is the thing, the walk that, Ariel, what's the name of the thing we have in Boston about the revolution, where people walk along that line, that red line, that blue line?
Oh, the Freedom Trail?
Freedom Trail. They did part of the Freedom Trail. And then they had this, thank you very much. And then they had this fabulous lunch. I went by, I couldn't believe it. It was wonderful. But this idea of the village model, if you can, there's resources, you can help start village models in your community. It's growing, it's booming. I think it's very much the future. And next slide, please, Ariel. I had the great fortune of being mentored by this person when I was a very young man. And she taught me many things, but this is one of my favorite of her quotes. We used to drive around in the Bronx, and she's just a wonderful person. But it's true. It's like the most terrible poverty is to be alone. So I commend every single one of you who are just, if nothing else, just for your interest in addressing this with this very wonderful generation, this population of older people. And with that, I'll check the chat.
Wonderful. Thank you so much, Dr. Miramaldi. We have just a few minutes. I don't see any questions yet in the chat, but this is the time. If there's something that you would like to share, so appreciate folks sharing their observations and reflections earlier, and certainly would be so interested, along with Dr. Miramaldi, to hear if there's work you're doing in this area or any reflections you have. As again, this is a topic that's so relevant to this older population. It was before the pandemic, was during the pandemic, and will be beyond that, but certainly welcome any points of feedback or questions. And while we kind of let folks type if they wanted to type. Oh, yep, will you see the video again? Yes, absolutely. So we will send out an email after this session with a PDF of these slides and a link to our YouTube channel where this video will be. We like to have our webinar recordings closed captioned for folks, so that will be up shortly. So you'll get information about that, but yes, this will be available as a resource, certainly. I will say when you receive this slide deck, and I'll advance a couple slides, I'll come back to the survey, but you'll see that there's some additional resources, just some of those assessments Dr. Miramaldi talked about, a few other resource slides we weren't quite able to get to today. So, oh yes, thank you. I see that that Tiff mentioned that those who did fill out the poll in the beginning, apologies for Zoom being a little bit delayed, but definitely know that this is a group that knows that older adults certainly may experience more social isolation and loneliness than some of their younger peers. And so appreciate Tiff sharing that information. But yeah, so I don't see any other questions, but again, always welcome additional feedback. If you are filling out the survey and can think of other topics you'd like us to focus on in the future, we'd love to hear that. Especially love the mention of the importance of getting caregiver buy-in a little bit earlier in the chat. We do have many activities of ours that focus on caregivers and their needs and how that impacts the care that they can help provide older adults, and how important it is for health centers and other organizations to really partner with family caregivers especially. So appreciate that comment, but we do hope you'll give us just a moment or two of your time additionally to fill out that short survey. Anything you'd like to pass along to Dr. Miramaldi, you can do that in that way, or send us a quick email. We're happy to pass along any questions or feedback. And we certainly thank you so much for your participation today, and for those who are viewing the recording after the fact. Certainly understand that schedules can be challenging, particularly in the past 19 months or so. So feel free as well to get in touch with us if you're viewing the recording and have any questions or concerns. So thank you again, everyone. Thank you so much, Dr. Miramaldi, for your time, and have a wonderful rest of your day. Take care.
Thank you.